Welcome students, welcome to another session of MCQ Live. I'm Dr. Abhishek and the first question for today is splinter hemorrhages are suggestive of. Your options are A. Myocardial infarction, B. Deep vein thrombosis, C. Pulmonary arterial hypertension and D. Infective endocarditis. So these are your options. If you know the correct answer, please write in the live chat. Splinter hemorrhages are suggestive of. Your options are myocardial infarction, deep vein thrombosis, pulmonary artery hypertension, and infective endocarditis. Will you write the answer? I'm Dr. Abhishek, your mentor for Medico Apps MCQ Live, and this is the 10th session on 4th of May, as you know, 5 p.m. A lot of my students keep telling me that, sir, please take a lot of MCQ sessions because whatever we learn in theory sessions, we tend to forget. But whatever you teach, via MCQs, that stick to our brain. So this is an effort towards that, where every week 3 to 4 sessions I'll be taking all in the evening at around 4:30, 5 o'clock, so that you can learn these MCQs. All of these are previous year MCQs on high topics, so that you can learn these, and many of these will be repeated in your examination. If you're first to our channel, make sure that you subscribe to our channel. If this is your first visit, hit the bell icon so that whenever we go live, you get a notification. Give this video a thumbs up because it makes us feel very, very good. If you have any questions on whatever I have taught you today, you can just simply write in the comment below, or even if you have some suggestions regarding upcoming future sessions, you can just write in the comment and share this video with your friends so that they can also be a part of this MCQ Medico Apps live discussion. So having said that, let's look at this question. Splinter hemorrhages are suggestive of anyone would want to give an answer to this. So the correct answer here is infective endocarditis. Okay, so let me show you an image of how an splinter hemorrhage is seen. Now this was a straightforward single liner question, but it can be formed in a clinical question, and then they can show you an image and you may be asked according to that. So this is typically what a splinter hemorrhage will look like. This is what typically. So basically they are linear petechiae in the mid position of the nail bed. Okay, all these you can see, these are linear, petechiae in the mid position of nail bed, and they are suggestive of infective endocarditis. Very good. Okay, splinter hemorrhages. So I've shown you the image. Let me show you some other images also. Again, you can be shown an image, and here you have been again given a history of infective endocarditis patient and with this tender subcutaneous nodules. Okay, so what is this nodules called as? Again, it can be given as a clinical question, it can be given as an image based question. So here you have a tender subcutaneous nodule on the pads, you can see here in the hands. So what do you call this nodules as? Again, this is a very, very one of the classical findings in infective endocarditis, and these are your ossular nodules. Okay, and one very, very important thing which you have to remember about this ossular nodules, that they are tender, which means when you touch them, when you press them, you will have pain. Okay, so this is ossular nodule. Let me show you another image and try to guess what is this lesion called as. This again is a seen in infective endocarditis. Again, can be given as an image-based question. Okay, so you can see some maculae, and where they can be present in the palms and in the soles. Okay, so in the soles of the feet or even on the palms. Okay, remember they are non-tender. Okay, so they are non-tender. Any guesses? What do we call these non-tender maculae on palms and soles? Anyone? So these are called as Janway lesions. Okay. Another very, very important finding in your infective endocarditis patient. Remember? And the last is this retinal finding. Okay. So what you see is retinal, change that color, these hemorrhagic spots in the retina. So what are these hemorrhagic small spots called? So basically these are retinal hemorrhages with small clear centers. Okay. Classically, you can see this clear center here. You can see the clear center here. And this is what we call as Roth spot. These are not very common, these are rare only. But again, so three image based question I have shown you. Okay. So first was your splinter hemorrhages, sign of infective endocarditis. Second is your Janway Osler's nodule. Third is your Janway lesions, and here remember it is non-tender, whereas Osler nodules was tender. Okay, and the last is your rock spot, which is a retinal hemorrhage with small clear central clearing. Okay, is everybody clear? So these are beautiful images which can be asked in the examination. Let's look at the next question for today. The most hydrophobic amino acid. Classification of amino acid again is a very important question. Most hydrophobic amino acids. Your options are glycine, alanine, isoleucine, and valine. Okay, so these are simple amino acids, and these are branched chain amino acids. Okay, so most hydrophobic amino acid you have to tell. So which is the most hydrophobic amino acid? So till you think about the answer and try to write the answer in the comment below. Let me talk about Medico app's daily update which we send. So I personally have created multiple WhatsApp groups. This is all admin post only group, which means only I will be posting updates. And what kind of updates generally I post? Generally 2-3 updates every day I will be posting. They will be concept card. Concept card I'll talk to you in detail towards the end of the session. There will be short videos, quizzes, master classes. You know, whenever I go live, you will get a notification there. Free PDFs, mini courses. So all these things free of cost you can get access to on our daily update groups. And remember, as I told you, it is admin post only, which means we only will be posting. There will be no good morning, good evening, good night messages in those groups. And if you want to join, you can go to medicoapps.org/groups. And if you are a first year student, join the first year group, because then you will be only getting updates related to anatomy, physiology, and biochemistry. If you are a second year student, join only a second year group. So this way, what will happen is you will get update only and only related to your own subject. Okay. So let's talk about the classification of amino acid based on the polarity. So when we talk about uh, okay, just 1 minute. I hope. So when we talk about amino acid, okay, the screen alignment has gone. Just correct it. Okay. When I talk about amino acid classification, okay. So amino acids based on the polarity can be, you know, classified into polar, also called as hydrophilic, and non-polar, also called as hydrophobic. Any doubt in this? So when we talk about amino acid based on the polarity, you can have polar or hydrophobic and non-polar or hydrophilic. Okay. And when we talk about polar amino acids, okay, again it is divided into charged and not charged. Okay. And when we talk about charged, it can be acidic and basic. So acidic amino acids are positively charged or negatively charged. So they will be always negatively charged because they will lead the hydrogen ion, so they will become negative. Or basic amino acids, okay, because they will accept the hydrogen ion, so they will become basic. Okay. So when we talk about acidic amino acids, what are the acidic amino acids? There are two acidic amino acids: aspartic acid and glutamic acid. Clear? Any doubt? When we talk about basic amino acids, there are two, you know, basic amino acids, non-aromatic and one aromatic. So we know the aromatic amino acid is histidine. Okay, and remember, it's very important. Histidine is a basic amino acid, so it's a charged amino acid. It's a polar amino acid. And then, what are the basic amino acid? Anyone? It is asparagine, and glutamine. So these three are the basic amino acids. So this group is what we have as the charged amino acid. Okay. So these are all polar and these are all hydrophilic. Because they are charged, they will be hydrophilic. Let's talk about few amino acids which are not charged but hydrophilic, which means they don't have a charge, but they are hydrophilic. Okay, which means they will dissolve in water. So anything which an OH group. So what are the amino acids with OH group? So we have got serine and threonine. Okay, so these two will be not charged but hydrophilic. Then the second is glycine. Glycine is a very the smallest amino acid. So even though it is not having any charge, but still it will be dissolving. So it will be hydrophilic. Okay. Then you will have anything with SH group. So we have got cysteine. Cysteine, this is hydrophilic. Okay, because it has SH group, so it will give hydrogen ion and it will become hydrophilic. So these are the hydrophilic amino acids. Rest everything is hydrophobic. What are, let me just enumerate it. So one is all aromatic amino acids. All aromatic amino acids become hydrophobic, which means they will have negative affinity towards water. They will not dissolve in water. Okay, except as I told you, histidine. Remember, histidine, even it is an aromatic amino acid, but it will be dissolving in water. Why? Because it is a basic amino acid. Any doubt? All branched chain amino acid. Okay, then we have one with your sulfur group, methionine, with SH group. Cysteine was hydrophilic, not charged but hydrophilic, but and the last in this will be, your alanine. Any doubt in this? So these were all the non-polar or hydrophobic amino acids. So this classification you should know even in your dreams. Even in your dreams, if they ask you, because lots of questions keep coming on classification of amino acid. And can anyone tell me why classification of amino acid becomes very important? Why classify? Why acidic amino acid, basic amino acid, hydrophilic amino acid, hydrophobic amino acid becomes very important? So we see our body is made up of water. So every protein should have hydrophilic amino acid on its exterior and hydrophobic amino acids in the interior. What will happen if something changes? If a hydrophilic amino acid is replaced by a hydrophobic amino acid, what is going to happen? Suddenly the protein will not be soluble, like you see in the case of sickle cell anemia, HBS. It's not that soluble, which leads to the sickling. Okay, so hydrophilic amino acids on the exterior and hydrophobic amino acid, because they will repel water, so they will give the three-dimensional structure to the protein. So these hydrophilic, hydrophobic amino acids, where they are present in a protein, actually plays a very important role in the structural, this of the protein. So still we know, so glycine is hydrophilic and rest all the three we know is hydrophobic. But we are not able to answer the question, that is which of the following is most hydrophobic. So as a concept, remember, the bigger the organic molecule is, more it will be, less it will be water soluble. Okay, is it clear? The bigger the molecule will be, right? Okay, so now let's look at the structure of these, the structure of these three. So let's look at alanine. So alanine, so this is the general amino acid, and here if it is a methyl group, it becomes alanine. Okay, if it is a, C and 2 carbon, then it becomes valine. Okay, I'm just talking about this because this portion for all amino acids will be same. Okay, this portion for all amino acids is same. It is only this side chain which is it. So this is alanine, this is valine, 3 carbon. Now with 4 carbon, what you have got is one this arrangement and one this arrangement. So this is your leucine, and this is your isoleucine. Okay, and by structure we can see that this has the largest chain, so it will be most hydrophobic. So the correct answer is C, isoleucine. Is it clear? So this was a relatively not so easy question where you had to know the structure also to answer this question. But if you know that alanine is this, valine is this, leucine and isoleucine, you could have easily solved this question. But again, I'm going to tell you that this classification is of super importance, and lots of time in your examination you will get this questions. So let's look at this. The correct answer is isoleucine. Any doubt in this question? So let's look at this question. Antiretroviral therapy in HIV infected patients should be initiated at. Your options are when the CD4 count is less than 500, or clinical staging, WHO clinical staging in third or fourth, or the option B is when the CD4 count is less than 350 cells, or WHO clinical staging is third or fourth when the CD count falls less than 200, or the clinical stage is 3 or 4, and any CD count regardless of WHO clinical stage. So which of the HIV or HIV patients will be going for antiretroviral therapy? Anyone knows the answer? Kindly write in the comment below. Anyone knows the answer to this question? So saint or sinner is saying D. Ravi, any option from you? Ritesh? So the correct answer actually is D. Any CD4 count, any CD4 count, or any WHO clinical rating doesn't matter. The moment the patient is HIV infected, you will have to start the treatment. And why is it so? What is the rationale? So first of all, an early HIV antiretroviral therapy has been shown to reduce the morbidity and reduce the mortality of these patients, because it will reduce the viral count. Okay, and another very important goal is that to reduce the risk of HIV transmission. HIV transmission. So these are the two goals. First of all, for the patient also, there is a reduced in the mortality and the morbidity if they are put on, immediately on antiretroviral therapy. We can have a complete session on what antiretroviral therapy, how and when to use, and it is also very important when you talk about reducing the risk of HIV transmission. So these are the two reasons why we don't wait for the counts to fall or the clinical stage to increase. We immediately any CD4 count or any clinical stage we start the treatment. Okay, let's look at another very important topic, which frequently gets questioned either part of a surgery or pharmacology or medicine. Which of the following is not true about thyroid stroke? Your options are A. Symptoms are vomiting, diarrhea, jaundice, and seizures. Mortality rate is as low as 5% with treatment. Precipitated by acute illness, surgery on thyroid, or radioactive iodine. And propyl thiouracil is the anti-thyroid drug of choice. So, what option, according to you, is not true about thyroid stroke? So, anyone wants to answer this question? What, according to you, is not true? Thyroid storm is a super important topic for your PG entrance examination. Okay, so let me take you to the theory of this important topic, and then we can come and see what will be the correct answer. So let's talk about thyroid storm. Causes of what are the causes of thyroid storm? So any patient, any hypothyroid patient, if he stops the anti-thyroid medications, so cessation of anti-thyroid medicines. So anyone who stops these anti-thyroid medicines, suddenly they may be prone for these thyroid storms. Usual causes: any stress on the body, for example, any infection, okay, or trauma, okay, or even so any surgery, especially thyroid surgery of an unprepared patient, or any other surgery may again cause thyroid storm. Two important things. One is use of radioactive iodine. Okay? Radioactive iodine therapy can precipitate thyroid storm, and a very important drug which is very frequently asked in your examination It is amiodarone. Administration of amiodarone or even exposure to iodinated contrast agent. So these patients, if they are sent for contrast studies, iodinate, and if an iodinated contrast is used, even that can lead to precipitation of thyroid storm in these patients. So how do the patient present to you? So the presentation is first with fever, high grade fever. There can be central nervous system. The patient may be agitated or even depressed, and GI dysfunction like vomiting, nausea, all those things will be there. GI symptoms will be there. Typically, these patients start going into hepatic failure, and generally, a lot of the morbidity or the mortality is related to the cardiovascular. So in cardiovascular, they will start having arrhythmias, okay, arrhythmias, and we lose a lot of these patients because of arrhythmias. So this is how. So what causes it? Sudden cessation of antithyroid medications, infection, thyroid or non-thyroid surgery, trauma in these patients, or amiodarone, or use of iodinated contrast agent, even radioactive iodine therapy. How do they present? High-grade fever, agitated or depressed, GI dysfunction like nausea, vomiting, jaundice, and hepatic failure. And most of these patients will start having arrhythmias, because of which we lose it. And generally, cardiac failure, arrhythmia, or even hyperthermia can lead to mortality as high as 30%. This is a clincher. So we have a very high mortality. Out of 10, you will lose 3 patients, either primarily due to cardiac failure, arrhythmia, or even because of hyperthermia. So these 3 are the leading causes. Mostly it will be CVS related causes. Even hyperthermia can cause mortality in these patients. And how do we? So the mainstay is basically propyl thiouracil. Okay. Propyl thiouracil. Basically, we give it in a very high dose, 500 to 100 milligram in loading dose. Very high dose, basically either orally or through nasogastric tube or even through rectum. And what essentially it does, it will inhibit the conversion of T4 into T3. So this is the mechanism of action. It will inhibit the conversion of T4 to T3, and that is why it is the anti-thyroid drug of choice. Again, the management of thyroid storm has been asked very often. So let me quickly take you through that. So let me talk about management of thyroid storm in detail. Okay. So what do we use? We have to use ice packs, antipyretics, because the fever is very high. So we can have ice packs, antipyretics, even IV fluid, maintenance of what you call the hydration status of the patient is very important. Then we also use propanolol. Why propanolol? Because it will block the adrenergic effects. Okay, it will block the adrenergic effects. Okay, and I have told you about propyl thiouracil. Propyl thiouracil. This is the drug of choice in the management and its major function. So this you cannot forget. So what it does, it inhibits the conversion of T4 into T3. Okay, and it also, so this is the primary mechanism of action. It also decreases the release of thyroid hormone from the gland. Thyroid hormone from gland. So it works both the ways. Majorly stops the conversion of T4 to T3 and also reduces the release of the thyroid from the gland. Uh, Another very important, we use steroids in these patients, corticosteroids. Okay, and how does this corticosteroid do? Again, they will primarily inhibit the T4 to T3 conversion. We also use Lugol's iodine. Can anyone tell me what is the function of Lugol's iodine, or even sodium iodate? Sodium iodate. What is the mechanism of action? So they will inhibit the release of hormone from the gland. They will inhibit the release of hormone from the gland. And obviously, For serious mortality, we can use something called as digoxin for management of arrhythmias. And if the patient is going into heart failure, then we can use diuretics and oxygen or whatever anti-congestive heart failure measures will be there. So management of thyroid toxicosis. If you are a final year student, you can get a full question on this, and obviously for MCQs also, various times they have asked the question. So now let's look at the question. So symptom presented vomiting, diarrhea, jaundice, and seizures. Yes, these are the presenting features. Even fever will be there. Okay. So these are the presenting. Mortality rate is as low as 5%. So this is wrong. So mortality can be as high as 30% even with treatment. Okay. Precipitated by acute illness, surgery, thyroid radiation, all this is correct. Propylthyroidism is the anti-thyroid of choice. So this is also correct. So in this case, the only wrong option is B. So this will be your answer of. Is everybody clear about this question? Is everybody clear? Okay. So how are you liking this session? If you are liking this session, give me a thumbs up in the comment, all of you. Whosoever is listening to this session and liking this session, just give me a thumbs up so that I know that you are there. Okay. Is the session fast, slow, or the pace is good? Is the session fast, slow, or the pace is good? Okay. Good. Very good. So now let's look at the last question for today. Which of the following is the marker of inflammation in inflammatory bowel disease, and which can also help us to rule out IBS? Okay, and your options are fecal fat, fecal lactoferrin, fecal trypsin, and fecal chymotrypsin. So which of these is used as a marker for inflammatory bowel disease? Okay. So remember, there are two very sensitive indicators, and now they are extensively used as a marker of irritable bowel, inflammatory bowel disease. Okay, one is fecal lactoferrin, fecal and the second is fecal calprotectin. Fecal calprotectin. When we talk about lactoferrin, it is highly sensitive as well as highly specific marker for your bowel disease. Okay, is it clear? It's a very specific marker for intestinal inflammation. And when we talk about calprotectin, now it also very closely correlates with histological inflammation. Okay, histological inflammation, and it can even predict relapse. So this is used a lot in your follow-up patients. So when you start a patient on treatment, so you can keep getting this calprotectin done to know how is the patient responding, because then it very well closely correlates with the histological inflammation. So both of these have started becoming integral part of your irritable bowel disease management. Okay, and they are actively used to rule out active inflammation versus the symptom of irritable bowel disease, because the symptoms will continue. But do you want to get very aggressive in the treatment is only when these indicators tell you to do so. Okay. Now, if you see, there are certain options in the option of in the questions where we were talking about fetal fat, fecal trypsin, and fecal chymotrypsin. So those, let me just put a few words about that. So they are markers of your chronic pancreatitis. So any disease which will have exocrine dysfunction, okay, pancreatic dysfunction. So any disease where there will be exocrine pancreatic dysfunction. Okay, what are the diseases? Chronic pancreatitis. Then you can also have cystic fibrosis. Okay, then you can also have a disorder called as Shawman-Diamond syndrome. Shawman-Diamond syndrome. So all these three will have a problem in the exocrine pancreatic function. And how do we measure it? So there are three. One is we can look for the fecal fat. We know that normally the lipase in the pancreatic lipase is what will help in digestion of the fecal fat, in the digestion of the fat which we eat, primarily in the jejunum. So if the fecal fat is increased, we can have indication towards the dysfunction of the pancreatic exocrine function. The second can be fecal trypsin and fecal chymotrypsin. So here we are directly measuring the enzymes which are produced by the exocrine pancreas, and if it is low, then we know that there is a limitation in the exocrine function of the pancreas. So again, fecal fat, fecal trypsin, and chymotrypsin, because they were mentioned, so I've just mentioned a few words what they are used for. If you see which of the following is a marker of inflammatory bowel disease, which even helps us to rule out IBS. So the correct answer here is fecal lactobacillus. So this, and this basically they are to rule out exocrine pancreatic dysfunction. Okay, right? So the correct answer here is B. This brings us to the end of today's session. Hope you really enjoyed it, and let me talk about our Midco concept card and what is why we created this concept card. So whenever I was talking to my students, the biggest challenge they face is revision. And why revision is always a challenge? Because there is so much to study. So when a student sits for revise, he does not know where to start, where to end. Revision also is super boring because when you listen to a lecture, when you solve MCQs, it's still very exciting. But once you have learned it and you have to relearn it, and you keep forgetting it, so that becomes super boring. And obviously, even no matter how many times you revise, you will keep forgetting it because that's a function of memory. So what we have done, we have created something called as Medico concept card. And what do we do in what we have done in the concept card is we have taken only high topics. So it's not that we have taken the entire syllabus, only the most important thing. You can compare it with marrow pearls or whatever you may call. So we have taken that high topic, we have converted into an image or flowchart based. So we have converted, taken high yield images or flowcharts, and we have made it very active in learning. Which means, suppose there is a flowchart, so they will not give you the entire flowchart in one go. There will be question marks, so you will have to think that what is there. So it is more like you are practicing with your friend. When he's asking a question, you are giving the answer. Then he's asking the next question, you are giving the next answer. So it's a very active learning when you use this concept card. You can simply go to Play Store and download the Medico Apps Concept Card app. So you can go to Medico Apps. You can search for Medico Apps Concept Card. Okay, in the Play Store, in the Google Play Store, you will get the app. You can download it and you can see it for yourself. And I'm 100% sure that you will really find it. If you want, if you are a follower on our Instagram, okay, the description of this Instagram channel will be in the YouTube or the Facebook comment in the Facebook description. So go and follow Medico Apps on Instagram, because here is where we will post the latest concept cards. So that way you can keep getting this latest concept card in your if you're in Instagram. So once again, a gentle reminder to join the daily update group. It's really vibrant. It's really getting you and it if you keep getting good messages every day, automatically you will start thinking of PG preparation. If you daily some small video will be coming, some small quizzes will be coming, some live session notification will be coming. So you will not feel frustrated. You will at least do that 10 minutes, 15 minutes, and slowly and steadily your preparation will improve. Again, if you are new to this channel, if you like this class, give it the subscribe to our channel, hit the bell icon, like, comment, share. So this was the 10th session, and now we will be going on the last session for this week. Again, next week I'll again tell you the session. So every week I'm going to announce. So tomorrow again at 5 o'clock we will again meet. Again half an hour, 5-6 high topics, question their important concepts, so that you can keep learning. Keep. So hope all of you enjoyed it. With this, I'll end the session. Thank you so much, guys. Thank you so much. And again, let's meet tomorrow for another live session.